Okay. My motivation for this study comes from the reality of our daily life, of my child's entire life. It comes from a place of deep need to bring to attention the suffering that people with serious mental illness in community are challenged with every day. It also comes from a place of concern where my lack of input into my child's mental health care causes both chronic and acute deleterious consequences. It is of additional concern to me that mental health care needs are not addressed with the same gravity of ethics and consequence as biophysical health needs, potentially ignoring higher existential aspirations as goals of care. The mental health crisis experienced throughout North America highlights how unmet need has widespread and adverse implications on health outcomes. People with serious mental illness require support, if not comprehensive, to maintain their basic needs in community, including housing, a source of income, and access to health care. Personal variables such as maladaptive psychosocial skills and drug abuse, and clinical characteristics such as lack of insight can frustrate caretaking needs and deeply confound helping efforts. This struggle is exacerbated by sociocultural variables such as stigma and structural barriers, including deficits of affordable housing and transportation. A lack of health personnel, particularly psychiatrists, directly contributes to the mental health crisis, with prevalent reports of community clients, I quote, falling through the cracks, unquote, of the mental health system. A third of those struggling with schizophrenia worldwide do not even receive care. Although mental health resources play a critical role in community care, governments continue to fail to provide community-based supports, and consequently, many parents of adult offspring with serious mental illness have become de facto case managers for their children, taking on a substantial role in community health as their caretakers. Milliken and Northcott emphasize that parents struggle to manage in this role. With parents functioning in both a compulsory and obligatory role within an inadequately serviced and crisis-oriented mental health system, identifying the unmet needs of their adult child with serious mental illness appears instrumental. Nonetheless, parents have no actual legal, medical, or caregiving rights in respect to their offspring, these having been severed when their child turned 18. Consequently, while ethically beholden to care for their adult child, parents are marginalized and disenfranchised in care decisions, as well as frequently kept out of the conversation. It's notable that parents who care for their offspring with serious mental illness have been shown to have, and I quote, a strong interest in the service needs of their adult children and are generally excellent reporters about those needs, unquote. Correspondingly, across the literature, these parents consistently report a variety of unmet needs. The adult with serious mental illness unmet needs are a strong predictor of a lower quality of life, with the biggest influence on health outcomes being where people spend most of their time in community. Very little research exists that specifically reflects a parent's perspective on the unmet needs of their adult child with mental illness. The literature does contain several substantial texts on the broader topic of the family of the person with serious mental illness, largely produced pre-1990s. However, subsequent research has a comparatively narrow lens, focusing almost entirely on the burdens and needs of those families. It is notable that more studies are focusing on the perspectives of staff and health professionals, despite family input proving more reliable. A minimum of 300 articles were scanned for this review by title first and sample second if there appeared a possibility or hope of a family member's opinion being part of the data, and I did have to scour that thoroughly. Youth under 18 and adults over 55 were excluded in this search due to the special needs of these cohorts, although 4 overage adults are included in the data by Gerson and Rose. Other criteria excluded was literature pre-1995 to maintain relevance to today's unmet needs in the community. Also excluded is research that includes clients with dementia, primary chronic medical illness, brain injury, or developmental or intellectual disabilities, including autism. 5 articles were found which include or center on the investigation of unmet needs of people with serious mental illness in community, largely reported by their parent caregivers or another involved family member. These are a 2016 study from India, Healthcare Needs of Remitted Patients with Bipolar Disorder, a comparison with schizophrenia by Nioji et al. A 2012 Swedish study, Needs of Persons with Serious Mental Illness Following Discharge from Inpatient Treatment, Patient and Family Views by Gerson and Rose. And from the United States, we have Needs in Outpatients with Schizophrenia, assessed by the patients themselves and their parents and staff by Phildamo et al. 2003, and Unmet Needs of Persons with Chronic Mental Illness, Relationship to Their Adaptation to Community Living by Perez from 1997, and Patrick and Prucho's 1996, Mothers' Perceptions of Service Use and Unmet Service Needs for Their Adult Offspring with Chronic Mental Illness. Millikan and Northcott's redefining parental identity, caregiving, and schizophrenia is significant for its findings that parental identity shifts due to trying to take care of the needs of offspring with serious mental illness. The research is more aligned with the burden of parental caretaking. However, it remains a part of this canon for its substantial commentary of the adult child's needs by the parents, as well as its discussion on parental caregiving rights. These 6 studies are derived from the disciplines of nursing and psychiatry, and all are quantitative pursuits, with exception of Millikan and Northcott's grounded theory research. 4 of these studies employ the Camberwell Assessment of Need, I will refer to that as the CAN, as a measuring tool, as well as CAN variations and other adjunctive scales, interviews, questionnaires, and inventory style assessment. The 2 studies that don't rely on the CAN, which are Patrick and Perez and Patrick and Pruchno, were both developed around the same time as the CAN instrument, which was 1997 and 1996, respectively. Unmet needs tend to be explored within the context of schizophrenia, while other serious mental illnesses are less represented. The reality is that serious mental illness manifests in many constructs, and some articles, while not meeting my criteria, support a broader understanding of phenomena in relationship to family. A study by Ross et al., which examines LGBTQ people living in poverty, is considered for its critical discussion of groups living at the intersection of structural oppressions. That is a quote. It is reminiscent of the lack of voice parents experience and is one of the only mixed method studies found. An analysis was also completed by Fisher et al., which, while assessing perceived needs of adolescents, is useful for its explicit differentiation and discussion of perceived need from both a service user and family perspective in relation to family factors that act as variables. Torres Gonzalez et al. Is also contemplated for their assessment of variables of unmet need, and Guzma Parent et al. Is considered for their findings and commentary on informal networks and supporting unmet need. Although noted to be comprehensive and multi-perspective, the CAN's chronic use across the canon identifies a homogeneous mode of inquiry into unmet needs that results in a constrained perspective illuminated in Nioji et al. His research, which identifies the CAN's sociocultural limitations, concomitantly and perhaps consequently, the use of critical and cultural perspectives as methodology also appear lacking, with the theoretical models all limited to behavioral concepts, and the only organizing framework identified being Anderson and colleagues' predisposing, enabling, and need model in Patrick and Pruchno, which is also behavioral in origin. While this paucity of research design is disappointing, several authors stand out for their ingenuity in measuring unmet need within this affected population. These include Nioji et al., who created a CAN variation reflective of the Indian experience, and Perez, who developed a needs satisfaction scale for people with SMI and serious mental illness and community that contemplates quality of life. Isaac et al.'s study, Care Coordination from Reduce Unmet Needs of Persons with Severe and Persistent Mental Illness, has been included for their clever modification of psychologist Abraham Maslow's infamous pyramid, the hierarchy of need, to reflect results of the CAN. In other words, to categorize the unmet need they discovered in their research. This hybrid model is the inspiration for an adjunctive second stage of my research, whereby hermeneutical themes will be transposed into Maslow's pyramid providing an opportunity to analyze unmet need in the context of human fulfillment. The literature determines that different perspectives create a more comprehensive understanding of the unmet needs of the adult with serious mental illness. Existing studies concur that a parent's perspective has been shown to identify more unmet needs than their offspring report, and different needs than health professionals report. Neogi et al. Notes that a parent's perspective, sorry, that is not Neogi. The parent's perspective has also been shown to be more aligned with what their offspring report. The literature identifies family input and inclusion as beneficial, illuminating, and vital for, I quote, comprehensive assessment and management of needs in community care of adults with serious mental illness, particularly in maintaining well-being, improving quality of life, and in successful adjustment to community. The larger overall conceptual theme identified is that people with severe mental illness have multiple and complex needs that often are not addressed, with psychosocial support, friendship, psychological symptoms, and financial, occupational, housing, and medical problems the most often reported. Sorry, I have two cats on the other side of a door. Now they're on one side. Most literature calls for a focus on care coordination with families and a continued effort in mental health care planning to understand and address consumer needs from multiple perspectives. All the literature identifies the need for more resources for adults with serious mental illness. The entirety of the canon strongly suggests that without sufficient mental health resources, the mental health crisis will continue unabated. Common limitations identified throughout the literature include sample size, unvalidated instruments, and variables such as severity of illness, sociocultural environment, and/or different perceptions of need. The research question, my research questions, will attempt to deepen our understanding in the following inquiries. What are the unmet needs of an adult with serious mental illness in community according to their parent caregiver? What are the unmet needs of an adult? What is the lived experience of unmet needs of an adult with serious mental illness in community according to their parent caregiver? What are potential solutions to resolve unmet needs of an adult with serious mental illness in community according to parent caregivers? And how does this data reflect on the ability for a person with serious mental illness to attain human fulfillment? The available research provides us with quantitative data regarding unmet needs, largely according to an array of checklists. These results are useful but saturated with the can-dominating data collection. Stubert and Carpenter note that there exists a continuing need for more human subjectivity and interpretation in the expression of our lived experiences, and emphasize that nursing requires modes of inquiry that offer the freedom to explore the richness of this experience. Quote, in essence, to study phenomena beyond what is quantifiable. Qualitative research and method grounded in the social sciences offers a unique ability to explain processes and patterns of human behavior that can be difficult to quantify, and provides creative opportunities to study complex human phenomena such as culture, values, and relationships while still maintaining validity and reliability. Humanism is a central theme of qualitative inquiry concerned with the entirety of humans, including their experiences, desires, and needs. Embracing a person-centered approach with particular attention to growth, learning, creativity, and potential, humanistic philosophy enables subjective experiences such as unmet need to be explored with critical and innovative perspectives. My chosen analysis, hermeneutical phenomenology, is both a qualitative method as well as a humanist construct that supports the humanistic concept of unmet need. Hermeneutical phenomenology is a type of analysis concerned with the hidden meaning of lived experience found in language and text. It is particularly attuned to working with issues of mental health. Hermeneutical phenomenology supports analysis with a critical lens, is a critical consideration in working with marginalized populations. By translating descriptions from parent perspectives into shared themes of reference that resonate with human experience, hermeneutic phenomenology will provide the opportunity to cultivate understanding of the unmet needs of adults with serious mental illness by essentially unearthing deeper meanings embodied in the data, understood as linguistic constructions. These themes, otherwise known as essences, are derived through the reappraisal and reinterpretation of the participant's language and text, an exercise which can illuminate the true but hidden nature of human experience and brings a new paradigm of understanding to data. Canadian philosopher Max van Manen's perspective of hermeneutics that contemplates parenting as a pedagogical relationship will be used as a philosophical structure within the humanistic construct. Pedagogy's significance in constantly attending in a practical manner to concrete situations and relationships with children reflects the dynamic parent-caregivers find themselves in. Pedagogy is particularly relevant to this research as parent-caregivers seek to teach, provide solutions, and/or develop ways for their adult children with serious mental illness to function effectively with limited resources. This research will employ two stages of analysis, one primary, one secondary. An interpretive hermeneutic approach will firstly be used to identify concepts of unmet need in relation to themes of context and reference within the data. The unveiled themes will be analyzed, they'll be presented along with vignettes of the subjects to capture and express their organic narratives that, I quote, preserve the uniqueness of each participant's lived experience, unquote. Van Manen's procedural steps of phenomenological analysis will guide the process. The secondary analysis will involve transposing the translated data or themes into Maslow's hierarchy of need pyramid by correlating the thematic essences with the different stages of existential need that you find in the pyramid. A model will be created for this analysis. The results will be critically probed within the context of human fulfillment and ethics and will appear as an adjunctive descriptive commentary following the first analysis. The sample will consist of approximately 8 to 12 parents caring for their adult offspring with serious mental illness in the community. The adult offspring must have a diagnosed serious mental illness and be between 18 to 54 years of age, the same criteria I pursued in my literature review. The sample population will be drawn from a variety of urban and rural centers across British Columbia. They will be recruited through snowballing, networking, email, and posters through local mental health clinics, universities, and targeted organizations such as the Schizophrenia Society. Semi-structured interviews, open-ended questions, and an interview guide will be used to provide a starting point for data collection. And interviews will be structured around the concept of unmet need. Participants will be encouraged to share their stories, experiences, and feelings. Tape or voice recorder will be utilized to collect data. In vivo software will be used to transcribe, store, and manage the data. However, to ensure a dependable hermeneutical approach, the researcher will examine the transcriptions and engage in phenomenological reflection of the data outside of in vivo support. The researchers may go back to the participants to clarify meaning required. Potential outputs and outcomes of this study are that data from the study will bring to the spotlight a critical yet understudied paradigm in the mental health care landscape, in addition to capturing silent voices that should be heard. It will identify unmet needs in the mental health population, as well as bring attention to barriers to access and resources experienced by those with serious mental illness. It will identify gaps in service and highlight issues of health disparity. It will discover shared human experiences, expose existential denominations of unmet need in this population, provide opportunity for the critical and ethical contemplation of unmet need in relation to its impairment of human fulfillment. Will initiate a body of existential effects and potential solutions associated with these unmet needs. Examining unmet needs and their effects can shape health policy, inform nursing, improve resource delivery, strengthen family systems, and it supports suicide prevention. A further potential income, as identified by Perez, is that it provides improved quality of research in the context of unmet needs of adults with SMI and community. Researcher is a student of the Master of Psychiatric Nursing program at Brandon University. I am a practicing psychiatric nurse and a parent caregiver of an adult child with serious mental illness. Ethical approval for the study will be attained by the Brandon University Research Ethics Committee. And that's it.
If anybody has questions for Linda, you can either pop them into the chat or certainly unmute and ask away. Thank you very much, Linda, for sharing your study plans.
Thank you. I was wondering if everyone was still there. It was so quiet.
I'm going to go ahead.
There's a question.
Oh,
Yeah.
Sorry, did you have a question or? Oh.
So there's a question in the chat. Thank you for your presentation is what is first stated here by Catherine. I'm interested in how you will be defining serious mental illness in your recruitment criteria.
Yes. Well, actually by the DSM. That will be the criteria. And essentially, if you've been found, serious mental illness, I believe it's 1 year. 2 years, maybe off the top of my head, but it is the criteria according to the DSM that determines serious mental illness, and that's the one I will be following. I hope this means I explained it well.
You did great.
Thank you.
Yeah, I just wanted to say a comment. Thank you. I think this, I think often we forget about the caregivers of people who are experiencing a serious mental illness. And I just think back to even some of my work when I was interviewing older adults who had dementia. A number of them were also caregivers to people with a serious mental illness.
Mm-hmm.
And it just made me realize how little we think about the, continued caregiving responsibility. And I think that's important.
Yes, and considering they are a real, they're a very critical role in caregiving now with the advent of deinstitutionalization. Basically, the roles switched from psychiatrists, health caregivers to community, which in a larger part ends up being the family.
I agree with Rachel. I think this would be really interesting to hear like this added perspective, right? And that she's right. We don't often enough think about some of the other people involved in the situations that we're looking at. And I will be eager to hear how it goes and what kind of things you find.
Thank you. I appreciate that. It's a bit hard with this kind of research. I'm sort of in the sea of a lot of other interests that are topping research these days, and I'm kind of going back to the real basics. But I almost feel like we need to do that. I almost feel like we need a little bit of a baseline right now to see where things are at. Yeah, and to build upon there policy-wise.
It's interesting to me too, right? It's been a fair amount of time now. I feel like that policy did shift to kind of that whole looking at or systems trying to include and be very inclusive of the whole family as a team around care that's delivered. But have we looked hard enough at how that's gone? And I think this will shed some light on that. So again, it'll be good. Are there any other questions from anyone else? Marian, did you put up your hand there?
I was just going to jump in and share sort of my interest in this topic. And I'm really interested that this research is going to be done. I think it's really important. I've been part of a systematic review team that is looking at parent or family, anyone who is a caregiver of adult patients who were admitted to a critical care facility, basically in an emergency kind of a situation, and how those parents and caregivers, family members, feel that the system is helpful or unhelpful for them because they are the caregivers. So their family member gets help or something happens at the hospital or at the unit, wherever things are happening. And then, of course, they will be returned home. And then the caregivers are part of, trying to do that then. And then our study was specifically to get at the point of how the caregivers feel about how the whole mental health system and the hospital system and all of these systems are set up. And anecdotally, we kind of know, if you have had people that are in these situations, that things don't go terribly well a lot of times, right? There isn't the communication maybe between the staff and the adult person with the psychiatric problem. And the whole privacy thing comes in. So caregivers or parents maybe can't know things, but they need to know things. They need to be involved in the decision of when does someone get discharged? How are they going to be cared for when they're out of the institution again, right? So, of course, our research, we did a systematic review and have found that is a huge problem for the people that are being caregivers. And so I really hope that our study and your research, and if more of this is done, there just has to be some way to make sure that caregivers and the hospital or healthcare staff and the doctors, that the communication is there and that things are set up so that it can be less, like, it's a terribly stressful time for everybody, right? For the person who's having the issue and the family and everybody, and there just isn't the time or the setup for things to work together the way that they need to for people to feel better cared for and supported and effective and like they're heard. So I'm very excited about the research that you're doing. So I think it's a huge thing that we need to address in our healthcare system. So I was really happy to hear about it. I misunderstood. I thought I was going to hear about research you'd already done, but I'm curious to see what will come out of your research. So that'll be really good information to have.
I know. Thank you. I decided to take my advanced readings into a presentation because I do believe in getting this information out there. So thank you for your comments. I would be very interested in seeing your research.
All right, I think we, sounds like we've come to another moment of silence and that we may be coming to a close on this. I see Rachel's added in the chat to indicate your name and affiliation if you're comfortable before you leave, so we can keep track of that. I do have a list of everyone who's been in attendance today. I know most of you. So if you wish to add that in before we sign off, or if anyone has any last questions, I will put that out there one more time. And then we will bid farewell for the day.
If I may also note, I do see, Catherine, thank you for your note. I will be doing my research soon. If anyone has any interest in participating, please contact me. I am looking for parent caregivers. I see only in BC. You know, I am still tossing that idea around of just doing cross Canada. I was kind of wondering if I should keep it limited to each province, specifically because of the way that mental health services are provided in different provinces. That's something that I'll follow up with my thesis advisor, because I would like to go across Canada. I'm just not sure if it's going to be suitable for this research. Thank you, Carol.
Thank you, Linda.
All right. Thank you, Linda, one last time. And thank you for everyone for attending today. And I'll look forward to seeing more of you and some of you in our next series that you'll hear more information coming up in November.
Okay, thank you, everybody. Thank you so much.